you find that magnitude of operation comparing this to that, and the literature support that is going more toward endovascular repair of these procedures rather than open surgery.
All right. All right.
Yes, thank you, Fadi. And can I just add to that? I think we did consider that very carefully, Samer. But I think in this particular young man with the double aortic valve disease and the aortic stenosis, in fact, well, I mean, you'll find out later, we felt the morbidity associated with thoracotomy in the presence of double aortic valve disease in an attempt to give him a more, a surgical procedure would probably be significantly higher. I think if we're talking just plain coarctation without bicuspid or aortic valve problem, then maybe yes, there's, one might lean a bit more towards the open surgery, which, like you said, the subclavian to descending aortic bypass would be quite easy, or ascending to. But in his particular case, we felt that opening his chest with that valve and the heart failure he was in, pericardial effusion, was asking, maybe we stepped too far. But,
So let me ask this question, whoever wants to answer. Why should do them both at the same time? I mean, surgery, open chest and thoracotomy, and fix the valve and coarctation same time.
Yeah, I'm very sorry, Samer, but I think the literature, there is massive data demonstrated that the open thoracic intervention is very related to spinal cord ischemia and stroke. And if you compare it to endovascular treatment, I mean,
I'm saying why don't you combine? I'm saying why don't you combine?
Oh, yeah, we spoke about that. This is the same reason. We were cardiac surgeons. We're feeling very reluctant because if you look to the CT, and we have not put an axial video, but the amount of collaterals in the chest, it is impressive, because this is not a 14 or 15 years old patient. He's 30 years old. I mean, it's a miracle. No, but yes, you don't find this kind of patients. I mean, it's a miracle he's alive. You look to him. So I never have seen the internal mammary arteries were looking to SFAs. I mean, I'm not joking.
Yeah.
I mean, so it was impressive. So if you tell me about thoracic intervention, open surgery, and you tell me doing endovascular repair, for me it is absolutely, I mean, I have no doubt I will go for endovascular.
Maybe I'll ask you this question for the fellow, because I'm sure they have that in their mind. I'm just trying to think loudly for the fellow, so that when they listen to us, they know. Because I'm sure someone will say, why just go with surgery? Why just do them both together? The reason why I'm asking this question, but I agree with you 100%. But let's see if anybody has any different opinion, or everyone agree on this plan. Look, everyone agree with you, Tanya.
I think, Simon, just for the fellows,
yes.
Sorry, for the fellows, if I may, the answer to that question is, why would you do a joint procedure? The answer is, if you absolutely have to, because I think we all agree this increased morbidity and maybe increased mortality. Now, if you can take the view that relieving the coarctation, that the valve will give you a few months for everything to settle down, then it makes it much more compelling to stage them. But when would we have done it together is if we felt that he would not have tolerated the reduction in afterload that came along with the coarctation. And in our case, we looked very carefully. We did a couple of echoes, and the view that actually the aortic stenosis that we were seeing, the jet we were seeing was probably exaggerated, and the valve cusp were separated. Because it's the aortic stenosis you worry about more in terms of the circulatory collapse rather than the regurg. The young heart, he'll manage the regurg. But the aortic stenosis, you can get into that spiral of hypotension. So that was the reason why we staged it. But the answer to that question is, unless you have no other choice, and the cardiologist is saying, look, he will not tolerate a reduction in afterload. And we weren't getting that message from the cardiologist.
Okay. So Tanya, let us tell us what you did, Tanya. Can you finish your presentation, please?
Yes, Dr. Sahra will continue. She has read it. Yes.
Maybe I have to, you need to unmute yourself, Zahra.
Okay, sorry. For sizing and planning pre-op procedure, there is this is the sizes for the arteries, a procedure, and this is the 3D. Planning covered the left subclavian artery, carotid subclavian bypass, percutaneous endovascular repair of the carcutation with aortic B graft 24 by 48 millimeter, measurement of a gradient pressure through right radial artery and pigtail through a left common femoral artery. 2800 CTAG GOR as backup in case of dissection or bleeding. So here we started the procedure. Patient was on supine position. We prepped the left side cervical area for carotid subclavian bypass. We dissected the carotid and left subclavian artery. Unfortunately, the subclavian artery was fragile and stitch wasn't stay. There was tearing, so we couldn't do the anastomosis. Decided to do the ligation, clamping to the subclavian artery, then started the endovascular procedure. So we started the endovascular procedure by making bilateral ultrasound guided percutaneous on the femoral artery, starting with the left side, pigtail and 6 French sheath placed. And right side, 2 pre-close Bruglide to upgrade 16 French sheath was placed. As you see here, this is the pigtail on the aortic arch, measuring the pre-carcutation pressure. And this is the another pigtail measuring the post-carcutation pressure. And you can see the gradients between pre and post carcutation. It's more than 40 as the pre-op evaluation. Also, we make sure the pressure from the aortic arch was the same from the right radial artery. So for the rest of the procedure, our reference was the right radial artery. After measuring the pressure, we deployed the implant on the left cervical artery, as you see here, and then we delivered aortic B gradient stents. After measuring the gradient pressure, we were satisfied for the stenting. The aortic B graft stent was dilated, the balloon 14 millimeter diameter between 2 to 3 bar pressure. So we completed the endovascular procedure by closure of the right femoral artery by Bruglide, but unfortunately it was failed. So we opened the femoral artery and closed with a patch. On the left side, only regular pressure done. We completed the subclavian procedure by continuous ligation, mattress continuous ligation of the subclavian artery with the umbilical tape ligation with pressure also. So bleeding, no bleeding from all sides. Patient was tolerated the surgery, then he shifted to the ICU. He kept in the ICU with uneventful issues. Post-op evaluation, left arm, he has unpalpable pulses, but hand well perfused, got capillary refill, warm, intact sensory and motor exam. PPI was 0.7, bilateral lower limb, palpable pulses with normal blood pressure. So post-op CTA done, stent in place, no migration, no recall. After a few days, he developed the left femoral artery pseudoaneurysm confirmed by ultrasound and treated by compression under ultrasound. So vessels was sent to the histopathology. Unfortunately, it wasn't enough to for evaluation. So most likely in this case, we have microfibrillar proteins deficiency within the aortic matrix, may be deficient in patients with bicuspid aortic valve and inadequate production of fibrillin 1 during valvogenesis may alter the formation of both the aortic cusp and root. Thank you.
Thank you. Very nice presentation. A very good job, guys. Congratulations, your successful case. Yeah.
No, thank you, Samer.
A rough course, but you did great. Finally.
Well,
yeah.
I would like to add it was a very difficult case, and nothing went as we planned in the OR at all.
Yeah.
So when you were talking about the stitching into the aorta, I don't want to think in the cardiac surgeons stitching in the aortic valve, because I've never seen an artery tearing and breaking the way it was breaking. That left subclavian artery, it was like paper. It was horrible.
Maybe the reason why endovascular is the best, because imagine if you have to do bypass from subclavian to descending thoracic aorta with this kind of subclavian, I think you'll have a major problem, right?
So the three arteries we touched, the three of them gave us a problem. So we couldn't stitch the left subclavian artery. The perclose proglide failed, and I can tell you, I think this is the first perclose proglide is failing in KSNC for me since I'm here. I have a very
maybe it's femoral artery also is very thin. Maybe femoral artery is thin. That's why the proglide didn't hold.
And he developed a pseudoaneurysm from a 6 French sheet.
Yeah.
And we were making very proper compression there.
Yeah, most of it has a connective tissue disease.
Yes, we were investigating a little bit on it, and most probably he is suffering a Marfan arthropathy. This is our suspicion.
Yeah.
But he recovered very good. And the cardiac guys are planning to do for him aortic valve replacement, probably after Ramadan.
Okay, that's good. Good job. Thank you. Any question to Tanya, guys? Anybody has questions? Or anybody with different?
May I just make a comment? Actually, yes. Two very quick comments. First of all, I want to thank Zahra. Zahra is a new F1. She's only been with us for 3 or 4 months. We landed this complex case on her last week, and she's presenting it to an international audience at very short notice. So well done, and you've done very well there. The second thing is that, I hold up my hand because I was the one pushing for the cortico-subclavian bypass, and I was the one who was unable to get the anastomosis. It was just postage stamping off twice. And we were stuck and caught. I was caught with my pants down a bit because I didn't anticipate that there might be an arteriopathy. And in the end, he didn't need the cortico-subclavian. My logic for doing it was that, one, it's a huge subclavian stump. The left vertebral I deemed to be dominant. And I anticipated that in future, he would be on cardiopulmonary non-pulse style bypass. So I thought, the more blood we can get going to the brain during that, the less likely he was to get a stroke. So he still has that bridge to cross. A bit of a learning point, it became apparent that I was not going to be able to stitch this. So I tied off the distal end with a nylon tape, a 5mm nylon tape, and I had a clamp right on the subclavian distal to the huge internal mammary, which is about 6 millimeters, and the vertebral. And I said to Tanya, I'm not going to be able to stitch this while the stump is pulsatile. So you need to plug it for me and cover it. And then maybe with the heat taken off the stump, it might be able to take a running mattress suture, which thankfully it did. So that was a bit of a stressful period of time. That's why we abandoned that and then did the rest of the procedure and then did it at the end. What have I learned from that? Well, I didn't know at that time that you can have a arteriopathy with bicuspid valve and coarctation. I do now. Would I have done anything differently? I probably would not have done the carotid, attempted it. But I'm just wondering, because Fadi has a lot more experience than we have on this. What do you think about that? And do you have any tips for next time on this, Fadi, or anybody else for that matter?
And I'm gonna go quick on that. Just a quick comment. I really these are very challenging cases. I really hats off. Really looking at it, and the issues that you went through are really scary, especially possibly blowout of the subclavian stump from the aorta. This is a disaster with a dead patient on the table. Very nicely well managed. All the cases that we have done, we didn't do any carotid subclavian bypass, but I totally understand the thinking process. Maybe every time we consider if we need to do it, maybe we will do it after the procedure if we need it. We never had to do it, but I totally understand the thinking process of trying to do that. The other thing is just a funny thing. You always do a complex groin, and you do a small sheath for angiogram on the other side, 4 French or 5 French, and you do very well with the complex groin, and your problem happens on the small sheath. So this is I really I really appreciate what you went through, and it's really frustrating. Yeah, very nice case, very challenging case. Thank you for sharing.
Thank you, guys. I think for the time seeking, we need to move to the second case. Michelle, is your slides ready, or you still have technical issue?
Hi, I will try to share my screen if it...
Okay, I think it's working now.
Okay, let's share.
Yeah, okay, now it's working, great. We can see your slide now.
Okay, so let's start from the beginning and...
Okay.
Okay, do you see my presentation, my slides?
Yeah, it's very clear.
Okay.
Michelle, very clear.
Thank you, Tanya, Isam, and Zahra for sharing the nice case of the coarctation. It was a nice case, complicated, but we have to learn from complications. My presentation is about celiac artery and SMA aneurysm. It's about a 50-year-old female social smoker who was known to have hypertension and dyslipidemia, well controlled on medications. She has a history of severe epigastric pain 4 months prior to presentation. It was associated with nausea, postprandial abdominal pain, and she was diagnosed with mesenteric ischemia in a peripheral hospital. We don't have that evidence from her CT scan, but she was started already on Pradaxa 150 milligrams BID since this accident. And she presented to our clinic to follow up with vascular surgery. She reports decrease in her epigastric pain, but pain still aggravated post-eating. We repeated the CT scan and angio scan, which showed a 1.9 by 0.6 centimeters celiac artery aneurysm with a 0.8 centimeter neck, and a concomitant small saccular SMA aneurysm was noted, 0.5 by 0.6 centimeters. So this is a celiac artery aneurysm. You can see it clearly on this profile picture. And we can already note the acute angle between the celiac artery, the SMA, and the aortic and the aorta. This is an angiography demonstration, and we see the hepatic artery, which takes off soon after the neck of the aneurysm. And we have a discrepancy between the celiac artery proximal to the aneurysm and the artery distal to the aneurysm.
So, Michelle, is it a true or false aneurysm? I got confused.
No, it was a true aneurysm.
True aneurysm, okay.
There was no history of trauma or whatever,
Okay.
which explains.
Because you talk about a neck, you said she has small neck, so I thought it's a pseudoaneurysm. So it's a true aneurysm.
It's a true aneurysm. Another true aneurysm, but a small one at the level of the SMA, 0.6 by 0.5. Now we were not sure if these two aneurysm or one of these aneurysm has to do with the symptoms of the patient, but we had a few questions. If there is any indication to treat this aneurysm, one or both aneurysm, which one to start with if we decide to treat both aneurysms, and what about the technique? So if we check the Society for Vascular Surgery guidelines, they recommend to treat for the celiac artery aneurysm. They recommend to treat any celiac artery true aneurysm more than 2 centimeters, which demonstrates an increase in size and with associated symptoms in patients with acceptable risk because of the risk of rupture. So we discussed the issue with and the treatment options with the patient, and we opted for endovascular coiling and possible stenting for the celiac artery aneurysm, which was the bigger one, and the shape was really it was different. It has a big neck and a long aneurysm. We thought that the risk of rupture here is very high. So what about endovascular options? We had to think about either stent grafting by exclusion by stent graft or embolization. Stent graft exclusion was discarded in our opinion due first to limited distal landing zone, close proximity of the hepatic artery to the aneurysm neck, because of the difference in sizes between the proximal and distal segments of the celiac artery, and because of the acute angle of the celiac artery that would have required axillary artery access with subsequent need of a large size introducer. So in our case, the aneurysm measured 1.9 by 0.6 with a wide neck. We opted for primary coiling. We went from the right common femoral artery for coiling, but we were unable to achieve adequate coil compaction, and we were also concerned about coil migration into the arterial lumen. So we decided to place a bare metal stent using the jailing technique to insert more coils. So this is the first tentative of placing. We were able to deliver 2 coils, but the compaction was not complete, and as you can see, we have a coil that were really protruding into the lumen. So we went from the axillary, so from the left axillary artery, and we delivered a balloon expandable stent 7 by 26.
Uncovered?
No, it was a bare metal stent.
A bare metal stent, okay. Yeah. Okay.
And we went again from the femoral side using a SIM1 catheter. We were able to go between the struts of the stent using a micro catheter. So we went into the aneurysm again through the struts of the stent, and we were able to deliver 1 more coil, and we were able to complete a compaction with complete exclusion of the aneurysm. The hepatic artery was still patent, the splenic artery and the gastric artery were all patent. So we were thinking, what about the SMA aneurysm? And if we check again the Society of Vascular Surgery guidelines, they recommend the treatment of any superior mesenteric artery aneurysm or pseudoaneurysm, even if it's a small, regardless of the size. The recommendation was to repair the aneurysm. But our attitude is to keep in this particular patient was to keep the patient on medical treatment, aspirin and clopidogrel, and do a close follow-up of the SMA aneurysm, which was, at our opinion, very small to treat. This is our presentation. What do you think about this issue? This is a small summary for the recommendation of the Society of Vascular Surgery that we reviewed for different visceral aneurysms, and for the celiac and the SMA. I just told you about the sizes and the recommendation to treat this aneurysm.
That's a nice slide. Nice. Thank you, Michelle. Very good job. Let me see what the people say about that. What do you think? Should we treat them? Should not treat them? But before we go, let me ask a question. What do you think is her symptom? You still think her symptom from aneurysm, or see something else?
Actually, I was not convinced that the symptoms were secondary to the aneurysms.
Could be. I mean, you said she has a severe angulation. Could be she has an SMA syndrome, because that she has severe angulation or deep angulation. I don't know how the CT looks like.
I'm not sure.
Yeah. All right. Who want to speak? Isam, what do you think, Isam?
Yeah, I mean, it's a great job, Michelle. Well done.
Yeah.
I mean, when you showed it, I thought that probably the best way would be to stent it and then through the stent coil it. Do you have any idea what the etiology was? I may have missed the beginning of that. But do you know why she's making aneurysms, splanchnic aneurysms?
We have no clue. But now we decided to go and do a workup for vasculitis or any unusual etiology. But we don't we don't have yet results. We don't have.
I mean, I think that's important in relation to the SMA aneurysm, because if she has got an active vasculitis, you may be able to treat her with immunosuppressants, so things that change the natural history of this this SMA aneurysm. It may stay that size,
But the scan we performed, the last one, is free of any signs of vasculitis or pathology. But we still have to go and look for any etiology.
Yeah, and with your permission, I'm going to steal this this last slide. I've done a screenshot. I think it's a very good teaching slide because for people to remember what size they treat aneurysms at.
Yeah,
thank you.
Nice. Yeah.
Lastly, does anybody have any experience with MFM stents? Samer, have you ever used MFM in this scenario? Multi-flow modulator stents?
No, not really. But I think it would work fine because FMA is a small one. They work very well. So I think they work very well, in this area. But I did not use them. The problem, they are stiff. I tried one time to use them the splenic artery, but it was very difficult because stiff, and splenic artery is very tortuous. So it was very difficult, really.
Isam, one comment. We have used flow modulator stents in those situations. We have used them in renal artery aneurysm. We have used them in splenic artery aneurysms. I must say, it's not a very rosy or every time successful story. And one of the splenic artery aneurysms that we treated with a very expensive flow modulator stent end up being like a plug. And we wish that we had used a 50 times cheaper plug to occlude completely the splenic artery than to use the flow modulator stent. But we have used it in renal and in spleen. When they work well, and we have aneurysms that are shrinking actually now without even coiling, just on flow modulator stent. Extremely expensive, but we're not sure whether it's the right thing to do or not. For this particular case, I think for Michelle, very nice case. I agree totally not to touch the SMA aneurysm at this point, very small. And if, God forbid, something happened to the celiac, because you still have a stent now in the celiac artery at the bifurcation, then you'll end up with two arteries that have active problems. I think sleep tight on that and then you will see over the progression what happened to the SMA. So I agree totally with the management, except that I would have done everything through the brachial approach rather than starting from the femoral. The other comment is Behçet disease. One should think seriously about Behçet disease in this patient because we are endemic for the Behçet disease in our region, and maybe this would be the closest diagnosis to think about.
Yeah, I agree with you, Fadi, about Behçet. We are doing the workup now. But regarding the brachial access, actually, I was starting by doing the brachial access, but I found out that brachial artery measured 0.3 centimeters. It was very small. So we went to the axillary. It was like 0.5, not very big artery. So that's why I hesitated, and and I didn't want to do a cut down or use a big French introducers. That's why I went from the femoral, but I was about to puncture the brachial before turning and going down to the femoral because it was a very small artery.
Clear, noted.
Thank you. Tanya, your hand is up. You have any question, Tanya?
Yes, it was regarding a technical thing. So I agree that it's better to go for this case and it's a very good presentation, very good case. I agree totally with the approach of the bare metal stent and through it putting the coils. I was just wanted to ask that, do you think a BBX could have made or would be a better choice than a regular covered stent? Because one of the reasons you didn't want to put a covered stent was because of the mismatch of the diameters, the proximal and distal.
Exactly.
And also because of the angle, because I understand with such an angle, you can have migration of the premonted balloon stent and it is a headache. But the BBX is not, it's not going to move. You can flare it. Has anybody experienced with that? I've never tried on visceral arteries, but I have used it and I know it's not going to migrate and I know it's very flexible.
But the problem, Tanya, is the VBX is a cover stent and you are very close to the, where is branches, hepatic artery and sphenic arteries, you may end closing,
but let's say if we are not close to that, but yes, you have this problem of the angle and the sizes. Would you consider going for that?
Use self-expandable uncover stent. Self-expandable, they can take two different sizes, no big deal, because this is like 19 uncover self-expandable stent. I think this area will work much better than balloon expandable stent.
Yeah, exactly, Samer. You're right. But the problem with the self-expandable is that we are not sure to deliver really the stent at the right location. That's why if we have branches or we have length that is not, we are not very comfortable with the lengths, maybe the self-expandable is a little bit tricky.
You mean you can get precise deployment?
Yeah,
I agree with that.
I'm just asking because the premonted balloon stents are really, you have to be very careful because they can migrate. They can migrate and then everything is spoiled. This is one of the things when you are thinking about delivering it. It's making you a trouble,
Yeah.
But now I think that the technology will change. I think it will change. Because now we have this one, but I think we will have more balloons like this, more remonted balloons. I think maybe our indications will change also.
I agree.
Ayman, I didn't hear your voice today, Dr. Ayman Fakhri. What do you think about this case or the case before?
Because I'm still in the OR.
Sorry. So you're busy.
But I was listening. It was a very interesting case. Thank you, Samer, and thank you, Michelle. You presented the case professionally.
Thank you.
Regarding my opinion, really, in this particular case, I go for self-expandable covered stent. I think I go for that. I don't like to make coils because it may end by piercing and it does not feel well. So I like to put a covered stent. It works much better, and it is very difficult to deploy. I agree for that.
Yeah.
The flow modulator stent is marvelous, but it is not easy procedure at all, and very expensive. I think the covered stent much better and gives a better results. But I think it is better to deal with the SMA. I don't like to leave it such like that. Although it is small, I go for fixing that too.
But I agree with Fadi. You don't want to stent into major arteries, because all this stent they have a problem in the future. I don't know how old the patient, but I think she's a young patient. I'll be reluctant to use SMA. At least, as Fadi said, if something happened to the celiac, at least you have an SMA is open. You would close the stent and then get to trouble. Then I think better to be safe than sorry.
Maybe all right, but I have to put in mind, and I have to go to fix it very soon because it's much more problematic, in my opinion.
I mean, he can do a CT scan follow-up and see how the increase in size. Then it's different story, if increase in size. But I've been follow a lot of visceral aneurysms in our clinic, and the majority really stay stable. Very few they increase in size. I mean, at least over years. All right, great. Ali Nahas, Muhammad, Ali, Dr. Ali from Syria.
Yeah.
What do you think, Ali?
Hearing.
You heard both cases. Any comment from any this case or case before? What do you think?
Regarding the case before, I think you mentioned you hear me?
Yeah, I can hear you. Go ahead.
You hear me? Yeah. Regarding the case before, I think that you mentioned a very important point that here we have not only the coarctation, but we have also the heart problem, the valvular problem. So my question was, how was the patient after you stented the coarctation? You mentioned a very, very important problem that what was the compensation of the heart? I would like to ask Dr. Tanya. Did it compensate it well or not?
Yeah. This is something
when
very
you
important.
When you drop the pressure.
Yeah.
The first question. The second question, if you please. The second was the patient has any Steele syndrome after that or no?
Okay, so the second question, very easy. Thanks to God, he doesn't have a Steele syndrome. The arm is compensated.
Any Steele syndrome, yeah. Any Steele syndrome because you negated the subclavian, no.
No, it doesn't have. It's asymptomatic. Regarding the other question, we talk about that, and the cardiac team was there as backup in case the patient was crashing. The perfusionist, everybody was ready. But once we did the gradient, I mean the delivery of the stent, the patient was doing well. He went to the ICU and he was tolerating well. They repeated. I mean, he was a little bit overloaded with fluids. He was a couple of days with Lasix infusion, but after that he was tolerating well. So, but it is a very important.
Did you think about sequential dilatation in order to permit the heart to compensate this drop?
Well, in this particular case,
to do that.
Yeah, unfortunately, we have another difficulty. The patient was from Yemen, and this patient was an NSB. So he received the treatment, but he received the treatment because it was done as an emergency. So we were not able, or we were afraid of not to be able to provide him following surgeries. Okay, maybe the ministry was denying to him the treatment. So we wanted to provide him a treatment that was durable. Okay, This was something that we discussed. And regarding the gradient we wanted to achieve, so some people is trying to achieve 30 millimeters of gradient, some people is claiming 20, less than 20, and some people is claiming like less than 10 millimeters of gradient. I have to say that we deployed the stent up to 2 bars, okay? We were feeling the stent was not dilating more, there was resistance. So it was about 15 millimeters. So the lumen of the stenosis was 4.5, and we dilated up to 15, I believe. And we made the first measure of the gradient, and we were very happy because it was less than 10. So we stopped. Stopped.
Thank you. The second case,
May I just add, sorry to that,
go ahead.
an important point here. This is again for the fellows. The aortic stenosis was deemed to be not as bad as the echo suggested. The surface area of the valve was about a centimeter squared. Now, what's interesting is what's going to happen to the aortic regurg. If the aortic regurg is due to a very high afterload, then you'd expect it to improve after you release the afterload. If it's due to a structural valve problem, then you'd expect it to worsen due to the increased aortic impedance and diastolic back pressure. Now, in his case, the aortic regurg got worse on the subsequent echo, which suggested that this was more of a structural valvular problem rather than the afterload.
Functional one.
Yeah, than a functional one. Yeah. So we spent a lot of time thinking and talking about this with the cardiologists. They were very confident that he would tolerate treatment of the coarctation, and in the end, they turned out to be right. I mean, he did get a bit wet post-op, and they had to give him some Lasix, but it wasn't anything, too worrying. So I think the message there is talk a lot, speak to the experts. The cardiac surgeons were standby in case he crashed after the dilatation, in which case we were going to put a balloon into the aorta and get them to open his chest and replace the valve. But thankfully that didn't come to fruition.
Yeah. The second case, I think it's a very important case. We see many visceral aneurysms, really. Last week, I did a 17-year-old male with Ehlers-Danlos syndrome with a pseudoaneurysm of the SMA, and I treated with cover stent. I had another case. I discussed it with Dr. Samer. It was a pseudoaneurysm of the hepatic artery. I'm thinking what I have to do. We discussed with Samer, but it's a very, very huge pseudoaneurysm. I think Dr. Fadi has treated very well this case. Thank you. Dr. Michel, sorry.
Thank you. Thank you very much, guys. Very nice cases. Should we stop, or I have a very quick short case? Should I present it, or guys, you want to stop? It's been an hour.
No, go ahead.
Okay.
Go ahead.
My case will be quick. I mean, it'll be quick. I'm very quick with my cases,
Yeah, very quick question before we go on.
Yes.
Is there ever a role for open surgery in the splanchnic artery, non-ruptured splanchnic artery aneurysms? And if there is, what is that role? Or have we killed the open operation with your catheters and stents and all these fancy gizmos?
Not really. I think we kill it because I have a patient who came with a ruptured splenic artery aneurysm, and we did in the vascular, even with the ruptures, So I don't think surgery has any rules now, with all tools we have, Very rarely we have to do surgery for this kind of aneurysm, unless like huge aneurysm. I think Ali has, Dr. Ali has in Syria. He showed me huge hepatic artery aneurysms, But I think, in the vascular killed the surgery.
Yeah.
All right, let me see if I can find my presentation very quick, guys. This one. Here we are.
Samer, meanwhile, Manchester United 2-0 with Paris Saint-Germain, huh?
Really?
Yeah.
Sorry. Manchester City, please.
Manchester City.
You have to be careful,
Yeah.
Sorry, Sam.
Don't you ever mistake
I
us
know
for
that
these,
you are a
these-
fan of Manchester United, Manchester City. Yeah.
And I'm rooting for Paris Saint-Germain. Like, unfortunately, it looks
No.
like,
Unfortunately, you are out now.
All right. You see my screen, guys?
Yeah, go ahead, yeah.
Okay, that's good. So this is a late presentation of embolized ESD occluder device. We have a 41 years old female who has a large ESD, about 28 millimeter. So what happened, the cardiologists, they took her and they did the percutaneous closure using the implant arterial septal occluder device, ESOD, of 32. So what size was, they oversized it. The problem is that 2 months after she had it, she had a kind of her symptoms, but she did not come back to the cardiologist. She decided just to stay home. After 1 year, she went back to them with the symptoms. When she came with the symptoms, the first thing they did a transthoracic echocardiogram and they found there's no ESD device. It's already migrated. So they sent her for CT angiogram, and it's the CSD, they found the ESD migrate all the way to abdominal aorta and sitting just above the celiac arch trunk. But patient has no symptom, completely she is asymptomatic. She has no vascular symptom, no abdominal pain, nothing. And if you look, sorry, let's go back, leave us here. This is a CT scan, and you can see the device sitting like that here, like a curve, taking the curve of the aorta. And just above the, you see how sitting here, exactly at the back of the aorta, and just above the, exactly at the origin of the celiac artery. I don't know if you have more images here. You can see the celiac artery here and SMA, but both are patent, and they're sitting in the back of the aorta. So it's taking the shape of the aorta and it's not causing any symptoms. So she has no symptoms and she's completely asymptomatic. They told her that she needs to be taken out percutaneously, but she refused. And she said, no, I have no symptoms, just leave it there. And they put on warfarin just to be on safe side. And after that, she got pregnant. And unfortunately, and really she was lucky that her pregnancy was really uneventful except for some shortness of breath and leg edema. But they sent her for another year. Of course, she continued to have her cardiac symptoms. So she went back to the cardiologist. It's been now 2 years since the embolize of the ESD. So they repeat the CT scan, and they scan same things, exactly the same. The device still in place, no thrombosis, both celiac and SMA are open, and nothing there, At that time, they said that she need to have it removed. They want to remove this one before they fix her heart. So they send it to us. So when she came to us, it's been now the ESD, the device being there about 2 years. So we said, okay, we can try to take it out. Let's go percutaneously, So I went there, I bought a 6-French sheath, long sheath from Medtronic with adjustable head, the one I use for endo anchors, because I can move the head so I can close to the device and can hold it, And I tried to retrieve it by using tri-balloon and endovascular, like here, tri-balloon. You can capture it, but you cannot pull it down. Then I put a big endovascular grasper, and I grasp it there. And when you grasp it, you can see it comes down. The picture is not very clear, but the moment I let it go, it goes up. So it's really stuck to the abdomen of the aorta. So even I can grab it, but when I pull it down, it goes down. When I let it go to jump up the way it was before. So that means it's already endocellularized with the abdominal wall, and it's become part of the abdominal wall. So I'm afraid that if I continue pulling, I will end with the ruptures. So, sorry, where we are now. So we decided, where is that now? Sorry. I'll finish here. Okay. So we thought that she needed to be taken by surgery, but she refused. And she said, no, I have no symptom, nothing, leave it alone. So we left her alone. We put on warfarin for a year because we don't know what to do. But after that, I said it's too much, so I switched her to the aspirin and Blavix. Has been following us with us for about 2 more years now. So it's been almost like 5 years since she had it. And every year she come, repeat a CAT scan and exactly the same pictures, no complications, nothing. So it's I just leave it like that. It's like when we do like when you put stent in the aorta all the time, like TVAR, EVAR. So I said to myself, well, just consider like an EVAR or TVAR. Just like leave it there. It's there. It's taking the control of the aorta. because surgery is a major surgery because, you know, it's a supraceliac. That means you have, and especially now is engorged in the wall of the aorta. So that means you have to open the aorta and you have to do possibly like, you know, maybe thoracoabdominal, lower thoracoabdominal incision to get it out. So we decided to leave it there. And we've been follow up now for the last 2 years. So now be 5 years and everything's fine. So what do you think, guys? Is this the right decision or we should go and take it out?
I will leave it.
So you agree? Just leave it there.
Yeah.
Okay. Yeah, because I mean, usually, I mean, if you try to look at the literature, the problem with the literature, all of them is done like within like a couple months, and they go and take them into vascular. I didn't see any case which came after like 2-3 years, you know, because most of them they discover it early because patients they get a heart symptom right away. So like, right away, like next couple of days or maximum after like a month or 2. So they have no time for endothelialization. So it's very easy to remove it. And we have a case which we removed endovascular before, but was like within a week, you know. But this is the first time I see a case like that where it goes for years, you know. So I don't know if somebody has different opinion or what do you think, guys?
Yes, please, Samer. I vote for leave it, but when I decide to remove it, I don't like to remove it endovascularly. I like to remove it surgical.
Even if it comes early. Why is this sound?
No, if it comes early, it's okay. This is no doubt it comes early. I get it in the vascular, but in such cases of chronic cases, I don't like to try to get it in the vascular. Yeah. I have a scenario, something like that, but a little bit different. I have a case of IBC filter impacted in the aorta and migrated and tilted at the bifurcation of both common iliacs. What to do?
I mean, I tell you, if it's down in the abdominal aorta, I mean, I will take it out, no problem. I mean, the only my problem here is because it's very high, but if it's lower in the lower abdominal or close to bifurcation, I will go and take it out because an easy approach and you can solve your issue forever. But this one, I'm reluctant because of position.
Yeah, you have a point.
Yeah.
You have a point. Leave it, but if you have to do, open it.
Yeah.
Prof Samer,
yes,
when you pull on the sheath and the patient moves down the table with you,
I'm saying I was really rough for like a couple seconds, and then I stopped. I said I don't want to have rupture. And you can see my grasper. I was grasping, and really you try to pull hard a little bit and sit down. You have to stop.
Yeah, I think Mother Nature is trying to give you a hint there, and I'd leave it, and quite frankly, I would stop irradiating her every year. Maybe you do it every 3, 4, 5 years, something like that.
I agree with that. What about anticoagulant? Do we need any anticoagulant? I mean, I stop warfarin and now put on aspirin, Plavix, but I don't even now. I think it's already industrialized, but maybe just put on aspirin or Plavix. I think
just one antiplatelet would be enough.
But leave it alone. Everyone agree on that.
Yeah, I agree. I wouldn't take it out.
Don't take it out.
No, it's very. Your
good.
coronary will make an spasm if you try to pull from that again.
Because I mean, I thought really, how much we put like metal inside the aorta? We put a lot of metals, right? We do a chimney, we have TVAR, EVAR. So what's the big deal? I thought let's consider like a TVAR. What's the big deal? Leave it there. Especially if it's nice, taking the curve. It's not like tilting or something like that. It's what I like. It's a nice curve.
It's endothelialized already.
Yeah, you see, taking the curve. So I said, let's leave it alone and hopefully she'll be. See how it took the curves aorta? That's what I like about it, So it was nice.
Do you think it's embedded, it's covered now, or maybe it's a question of diameter, of size? That's why you couldn't pull it down? Did you try to push it up or when you grasped it, when you were...
No, I think it's endothelialized because I grasp it with a grasper and not like you can see my sheet's very close to it and I get a grasper, not like even a snare. And I can really have it in my hand. I mean, my grasper when I pull it, and then when I let it go, it should stay in place if it's not endothelialized, but it just jump exactly where it was before. Like I pulled down like 2 centimeters, and then when I let the clasper go, it just jumped up exactly where it was before. So this tells me it's endothelialized, you know, otherwise it would be moved a little bit and did not move at all, not even a millimeters.
Yeah.
So I think it's endothelialized, yeah.
Yeah, I think you should leave it.
Yeah.
Yeah.
All right, guys, great. Thank you. Sorry I kept you late today. Thank you guys very much. Enjoy the rest of the night, and we'll see you next week.
Thank you.
Thank you.
Take
Thank
care,
you.
guys.
Bye-bye.
Take care.
Bye.
Bye.
Thank you.
Thank you, guys.
Thank you. Goodbye, everyone. Thank you
Bye.
very much.
Bye.